Thank you, Dr. Kumar, for including me in this symposium. Am I audible and my slides are visible, I suppose? We'll go ahead.
Yes, yes.
So I'm going to talk about the many phases of NVD in PDR. Dr. Kumar has a penchant for, conceptualizing very different kind of instruction courses, and this is one of them. And I was quite flummoxed when I was given this topic, but I hope I have been able to do justice to the topic. Now, NVD in PDR, why is it important? Because we all know that NVD is an important component of high-risk PDR. We all know that there is a risk of severe visual loss with a patient has a high-risk PDR and you don't treat them promptly with laser. So therefore, it's important that we do not miss NVD in a patient with diabetic retinopathy. Essentially, finding NVD is a clinical skill, that is picked up on diligent clinical examination. As Dr. Kumar has already emphasized, indirect ophthalmoscopy is an important tool in overall examination of the retina, but might not be a best way to pick up NVD because we can easily miss the fine new vessels on the disc. Slit lamp biomicroscopy is the best way to pick up, NVDs in all our patients with diabetic retinopathy. And this is what I would recommend that we do in all our patients to really pick up these NVDs and also NVEs in all our patients with diabetic retinopathy. Whenever new vessels are there like this, it's not a big problem to diagnose. I think anybody will be able to pick up these arborescent new vessels on the disc here and elsewhere. The raised new vessels like this on the disc and extensive new vessels here. So new vessels like this are very easy to pick up and not generally missed. However, clinically, we may not be able to have patients like this in all situations. We have patients who have very subtle changes on the disc. You can see here 4 examples of subtle new vessels. So in the second example, you can see that the natural pallor of the cup is obscured, and you can see that that could be an indication for presence of new vessels. And the pallor of the disc here and new vessels along the arcades, along the major vessels. So sometimes you may have to spend more time looking at these eyes in order not to miss these early new vessels. So when do you suspect PDR? I think Dr. Kumar has alluded to this. Any pre-retinal hemorrhage is by definition a PDR in a patient with DR, and we must make all efforts to see new vessels elsewhere or new vessels on the disc. Presence of any old or fresh vitreous hemorrhage again is an indication of PDR. They've seen NVEs in multiple areas. Spend some time looking at the disc to pick up any NVD and gliosis along the arcades. I think Kumar has really shown you many examples of NVE and how they look at various stages. Let me not spend much time on that. This is what I was talking about. A patient on routine examination comes with a pre-retinal hemorrhage here, pre-retinal hemorrhage here. So why I am stressing on pre-retinal hemorrhage is
some background noise is there. Please mute others. Please mute yourself, please.
Yeah. Am I audible now?
Yes, Murali.
Okay. Pre-retinal hemorrhage is an important sign of PDR. Why I'm stressing on this is we get referrals from our colleagues and patient has a pre-retinal hemorrhage and the patient is referred to us as a patient of NPDR or BDR. So that means the significance of pre-retinal hemorrhage has been missed in that particular eye. So any sign of pre-retinal hemorrhage, please look for PDR in these eyes. Now, another subtle sign that we see is sometimes condensation of vitreous and a gliosis on the disc. Sometimes it is very subtle, and this could be an early sign of PDR and a new vessel on the disc. Now, sometimes the new vessels on the disc are not so visible, but they're extending along the arcades, and you can see that they are, along the arcades, they are quite vascular and raised. And this also classifies as an NVD, because as Kumar said, any new vessel within 1 disc diameter, although this is more than 1 disc diameter, it's part of a neovascular complex within the disc. ILM folds are an important pointer to the presence of some traction and gliosis, and could be a pointer for presence of PVD in these eyes. Now, if you look cursorily on this eye, you may easily miss the presence of a new vessel. But when you increase the magnification of the slit lamp and then see, there is a fine network of new vessels on the disc that you can see. So it is important to examine the disc with a little bit more magnification than what you normally use, in order not to miss these fine arborizing new vessels that can be picked up on magnified view. So what are the tips I can give you to confirm or pick up these new vessels? One is use high magnification, as I've shown you in the previous example. One of the things that we don't use so much is a red-free light. That's a green filter that is available in the slit lamp. In all our slit lamps, this is available, and putting this red-free light can enhance the vascular pathologies and make the vessels appear much more brightly and easy to pick up. So use the red-free light whenever you are doing 90D lens examination in a patient. Of course, in any patient in whom you want to document, you want to confirm the presence, and clinically it is not possible to be very sure. FFA is the gold standard to confirm the presence of new vessels. And nowadays we have started using OCTA, especially of the disc, in order to pick up new vessels on the disc. As Kumar said, the new vessels can be found on the nasal side, above the arcades, below the arcades, and temporal to the fovea. These are situations where OCTA is difficult, but OCTA of the disc is easily done. And we have used this in clinical situations where we suspected the presence of NVD. This is, of course, if you look at clinically, the NVD in this eye is not very obvious. But however, when you do the fluorescein angiogram, you see the leakage from new vessels on the disc, and also there is another NVE along the inferior arcade. So FFA is the gold standard. And now we look at this eye. This eye looks also non-discrete, but when we look at the OCTA, we were able to demonstrate the arborescent new vessel on the disc, that is seen in this eye. Another example where the new vessels on the disc were not very obvious, but OCTA clearly showed the raised new vessels on the disc. Just few more slides. Asteroid hyalosis is another situation where you may need to do a fluorescein in order to confirm. And once we have NVEs present at multiple sites, there is no need to do an FFA in this eye. Hyperemic swollen disc and collaterals on the disc are two clinical situations where you might really feel a problem in distinguishing from NVD. The dilated vessels are never raised from the surface. They're always within the surface of the retina. And fluorescein angiogram can easily show the dilated capillaries on the disc. So collaterals, on the other hand, have a larger caliber. They have a corkscrew-like appearance. There is no branching. They are not raised, and there is no leakage on FFA. As you can see in this FFA, there is no leakage by the collaterals. So in conclusion, new vessels on the disc is an important component of PDR that should not be missed. A diligent examination using high magnification is required in all the eyes. FFA and OCTA can confirm, and overall you have to correlate with the overall clinical picture and arrive at the final diagnosis. I thank Kumar for lending some of the pictures shown in this lecture, and thank you all for patient hearing. Thank you.